you very much. Many thanks for inviting me to talk about the new therapeutic targets in PNH. I work in the National PNH Service, and it's my privilege to be here to talk to you about what's happening in PNH world. These are my disclosures. I'll let you read them. So I think the objectives of my talk, how I've divided the talk, is PNH, what have we achieved? And then I will briefly talk about the data on the approved drugs that are now approved for use in PNH, and then briefly talking about the upcoming treatments and the therapeutic targets in the world of PNH. So I think it's safe to say that anti-complement therapy, primarily the C5 inhibition with eculizumab, is the standard of care of PNH, and it has been for a long time. If we look at the first approval for eculizumab, that was in 2007, and the recommendation for treating patients with PNH was related to the complications of PNH, which include thrombosis or complications associated with hemolysis, such as renal failure and pulmonary hypertension. And then we found out that we should be using this in pregnancy as well. And there is an indication of hemolytic PNH manifested with high LDH and symptomatic anemia. So that formed the cornerstone of treatment of PNH for a long time. And it was a turning point for PNH treatment. And this is some data from our center where we are showing that patients who were treated with eculizumab had a 5-year survival rate of 95.5% for patients on eculizumab, versus the patients who were treated with supportive care, where the 5-year survival rate was 66.8%. So definitely the patients on eculizumab have got a life expectancy which is nearly reaching the contemporaries at the same age matched population. In terms of the side effect profile, the drug is tolerated very well. But is there a problem that these PNH patients getting? So this is the data from another study looking at 195 patients who have been treated with eculizumab, and 36% of the patients had lower levels of eculizumab than desired. 74% of the patient had signs of ongoing red blood cell destruction, and we can talk about that, whether that was intravascular or extravascular hemolysis. And then 18% of patients, which is nearly 1 in 5 patients, still needed transfusions after 2 years of therapy. And if you do some other tests like CH50, looking at the complement activity, nearly half of the patients had some complement activity detectable. This is just an example of a patient whose LDH was still very high at 900 milligrams of eculizumab given every 12 days. And when the patient moved on to 900 milligrams every 7 days, the LDH did drop down to reasonable levels. And then the dose could be increased to 1200 milligrams every 2 weeks. This gives you an example of pharmacokinetic problems with eculizumab, which is an ongoing issue with this therapy. So the second drug to talk about is revolutimab, and revolutimab was primarily re-engineered from eculizumab for PNH-dependent elimination of C5 inhibitors. So eculizumab backbone was used. There was some changes that were done in the complementary determining region, which were in the murine area, and what that helped to do is to promote the release of C5 in the endosome. And then there was modification done in the constant part of the antibody, which essentially enhanced the FcRn binding. What that resulted in is stark differences between the two antibodies. Both are IgG kappa monoclonal antibodies. The eculizumab has a half-life of 11 days, whereas revolutimab has a half-life of 49 days. Eculizumab is given every 2 weeks, but initially you have to give it weekly for first 5 weeks. Whereas revolutimab is given after first 2 doses is every 8 weeks, but it's a weight-based dosing as well. And nearly 1 in 5 patients on eculizumab need a higher dose. The licensing has happened in majority of the countries for revolutimab in 2018 and 2019. If we look at the data for revolutimab, there are 2 studies to talk about. This is the 301 study. This is the patients who are complement inhibitor naive, so they have not had any treatment for their PNH. Half of the patients were randomized to receive a revolutimab, another half were receiving eculizumab. The randomized period was 26 weeks, followed by an extension phase where the eculizumab-treated patients moved on to receive revolutimab. The table just shows you the weight-based dosing, which is done for revolutimab treated patients. The primary endpoint was transfusion avoidance and LDH normalization based on non-inferiority design. If you look at the 302 study, these are patients who have been on eculizumab for 6 months and they are on stable dose at that point. They are randomized to receive revolutimab or eculizumab, and then in the extension phase, again, everyone moved on to revolutimab, with the primary endpoint being LDH percentage change with number of secondary endpoints. And what the 301 data shows that the key primary endpoints in terms of transfusion avoidance and LDH normalization was achieved. So revolutimab was non-inferior to eculizumab from that perspective, and it met all the key secondary endpoints, which were again a non-inferior result for revolutimab. So there is some element of this that it favors revolutimab, but overall the key message is that this is a non-inferior drug as compared to eculizumab. Important thing to recognize is looking at the serum free C5 levels. And what I want to highlight in this is that if you look at the free C5 level, and 0.5 microgram mil is the important thing to look at. With revolutimab, you see very consistent blockage of the C5, and the free C5 levels are very, very low in revolutimab treated patients. And in eculizumab treated patients, you have these fluctuations where the C5 levels do fluctuate up and down, and I'm talking about the free C5 levels. So it appears that revolutimab provides a much better control in terms of the free C5 levels. If we look at the 302 study, and these were the patients who moved from eculizumab to revolutimab, again, you can see that it is a non-inferior result in terms of the primary and key secondary endpoints, and this study also achieved its endpoints. And based on this data, the drug got approved. And again, in this study, you can see the free C5 levels fluctuation. You can see less eculizumab fluctuation in this trial, but you need to remember that the patients going on to this study were on a stable dose of eculizumab for the last 6 months, which is the best of the patients who are treated in the PNH world. So clearly, the drug is effective. This study importantly gave us an answer on the breakthrough hemolysis. And breakthrough hemolysis is of different types, and I'll talk about it briefly. But in both these studies, 301 and 302, the breakthrough hemolysis was seen in a small number of patients, but essentially in the eculizumab arm in the 301 study, 10.7% of the patients were having breakthrough hemolysis as compared to 4% of patients in revolutimab arm. But if you look at the causes of the breakthrough hemolysis, when the C5 levels were above 0.5 micrograms per mil, none of the breakthrough hemolysis happened in revolutimab arms, and they were primarily related to infections, and free C5 levels were not raised in those patients, suggesting of another phenomenon by which the breakthrough hemolysis is happening in the revolutimab treated patients. In the 302 study, there was no breakthrough hemolysis happening at all in the revolutimab treated patients. Majority of the patients had anemia, fatigue, and hemoglobinuria. There were some patients who were treated with transfusions in the 301 study. I think the most important thing in terms of revolutimab is that the patients like it because the frequency of infusion is reduced. Patients are able to plan better. The quality of life does improve for patients as well. And convenience is obviously very important because this is a lifelong treatment. Patients who wanted to go on eculizumab and didn't want to move on, they were worried about the side effects of the revolutimab, which really are pretty much the same as what we see with eculizumab, and sometimes the anxiety related to the infusions as well. There's a lot of treatment burden associated with eculizumab treatment, and that definitely is reduced with revolutimab. Talking about the breakthrough hemolysis, there are two main types of breakthrough hemolysis we see with C5 inhibitor, and one is the pharmacokinetic breakthrough hemolysis. Quite easy to explain that your eculizumab levels are running low, CH50, analysis shows that the complement system, the terminal complement system, is still active, and the free C5 levels are detectable. And this is a nice diagram which kind of shows us that if you have got an incomplete blockage, you have got free C5 there, which can activate the C5b to C9, the MAC complex. But the pharmacodynamic breakthrough is difficult to explain. These patients have got normal drug levels. The CH50 appears to be blocked. The C5 free C5 is undetectable. And the proposed mechanisms are that there is a very high density of C3b on RBC generated high affinity C5 convertase. So essentially the C3b is able to activate the C5 despite convertase, despite being no C5, free C5 levels detectable in these patients. And the second thing is the cleavage of the C5 is happening even bound to the inhibitor or activation of C5 without cleavage. Now, these are proposed mechanisms. It's very, very difficult to prove this. Like I said to you, usually what happens with these patients is that they had a dose of revolutimab a week, 2 weeks before, and they start to hemolyze at that point. And usually it is a self-limiting event, usually induced by an infection or immunization. And it usually, you have to just give them blood transfusions during that time, and the complement activation, once that resolves, then the process stops as well. And really, you don't need to give an extra dose of revolutimab. That's what we used to do with eculizumab in terms of the pharmacodynamic breakthrough. What is the other mechanism of PNH, hemolysis in PNH? And I will allude to that in this cartoon diagram. So these are your red cells, and you've got your alternative and classical pathway. What is happening on the red blood cells is the activation of the C3, C4b, and eventually what is, you're seeing the GPI anchor protein CD55 and 59. But the eventual result is that once you have the C3 activation, you can convert that to C5 to C5b. And if you don't have CD59 or CD55, the formation of the membrane attack complex happens, and that insert holes into the red blood cells, and that causes intravascular hemolysis, which is a feature of PNH. When we give patients eculizumab or revolutimab or any C5 inhibitor, we are preventing the formation of this membrane attack complex. What we are not doing is stopping the process of the proximal activation, which is the C3 activation to C3b. And then with the help of factor I, IC3b and C3d is formed, and that makes these patients Coombs test positive in these patients. And then you've got lots of C3d on these red blood cells. And what you get in nearly every patient with PNH is extravascular hemolysis and the cells being destroyed in liver or spleen. And due to some polymorphism, sometimes the red blood cells will take longer. So we are converting an intravascular condition into an extravascular hemolytic issue. We've looked at this data. This is our 141 patients treated with eculizumab in Leeds. And what we find is that the patients who have had transfusions, 1 to 2 transfusions or more than 3 transfusions, had lower hemoglobins. Their reticulocyte counts were higher, and they had C3 deposition on the red blood cells, which was variable but persistently detectable on these red blood cells. And that's where the new drug pegcetacoplan comes into play. So this is a pegylated drug which is binding to the 2 core components of the complement system, C3 and C3b. It binds to the C3, prevents C3 convertase to convert into C3a and C3b, which are involved in inflammation and opsonizations. And it also prevents the formation of C5 convertase, and subsequently the MAC does not form. So this is a drug to prevent intra and extravascular hemolysis, and the main data comes from Pegasus study, which was looking at combination of pegcetacoplan with eculizumab in the run-in period for the first 4 weeks, and 80 patients were recruited. And then after the 4 weeks running period, there was a randomization to receive pegcetacoplan or eculizumab for 16 weeks. And then all the patients move on to pegcetacoplan. The patients who were on eculizumab monotherapy had a short period where they were given combination drug and then moved on to pegcetacoplan at that point. We've now got the week 16 analysis as well as week 48 analysis on this. This is the demographics, and I think the reason to put that here is that this is a really difficult group of patients who were transfusion dependent. A majority of the patients needed transfusions despite being on eculizumab, and a significant number of patients were on higher doses of eculizumab. The platelet count was reasonable in these patients, suggesting that this was not an aplastic population, mostly a hemolytic population. And a variety of other things were suggesting that these are the patients who were exhibiting severe extravascular hemolysis on a C5 inhibitor. This is the primary endpoint of the study, looking at the hemoglobin response. And you can see that in the run phase, where you combine the two drugs together, the hemoglobin improved from 8.7 grams per deciliter to 11.9 grams per deciliter. And as you move on to the randomized part, the patients who went on to eculizumab dropped their hemoglobins back to where they were before they received the dual therapy, whereas the pegcetacoplan patients continued to be benefiting from that. And I think the important thing to say is that 16 weeks is not enough in a PNH patient's life to get this analysis. And now we've got the 48-week data, which essentially shows that as the patients who got eculizumab and after 16 weeks move on to pegcetacoplan, they followed the curve which the pegcetacoplan patients were getting. So clearly an improvement in the hemoglobins. The transfusion avoidance was much better as well. So the patients, 85% of the patients on pegcetacoplan did not need a transfusion as compared to 15% of the patients on eculizumab. If you look at the reticulocyte count, you can see that the reticulocytes tend to drop very quickly in the pegcetacoplan group. And once they go back onto eculizumab, the cytolytic count goes back to where it is, suggesting that the extravascular hemolysis is putting a significant burden on the bone marrow. And as soon as they go back onto pegcetacoplan, the reticulocyte count tend to drop again. If you look at the 16-week data, this was clearly in favor of pegcetacoplan. If we look at the LDH results, the LDH is not very different between the two arms of the study. And we know that in patients with extravascular hemolysis, we don't see a very high levels of LDH. But even then, the LDH level tend to get better on pegcetacoplan. If you look at the facet fatigue score, there is some, I don't need to tell you, but again, it is very much mirroring the response to the hemoglobin response as we see with pegcetacoplan. So in terms of the primary and secondary endpoints of the study, the pegcetacoplan clearly, it was the change in hemoglobin from baseline was clearly in favor of pegcetacoplan, about 3.84 grams per deciliter improvement. Transfusion avoidance was achieved. Reticulocytes got better on pegcetacoplan. The LDH change was not that significant, but the facet fatigue score was again in favor of pegcetacoplan. But there is a problem with this drug as well, in terms of that there is breakthrough intravascular hemolysis, which can happen in these patients. And there are some patients on this study who had to come off the study because of the intravascular hemolysis that happened in these patients. And there are multiple reasons for that, and I'll allude to that in the next slide. But the Pegasus study clearly showed us that in patients who are exhibiting extravascular hemolysis, pegcetacoplan as compared to eculizumab was a better drug, albeit with a short follow-up of 48 weeks. This is one of my patients who essentially we monitored the PNH clone over a number of years. And if you look at the red bar, that's the PNH red cell clone. And the red cell clone actually went down quite a lot because of the hemolysis that we were seeing. But as soon as the patient went on to pegcetacoplan, you can see that the red cells are pretty much 100% in terms of the PNH clone, suggesting that these cells are surviving on pegcetacoplan. And if you look at the type 3 red cells, and these are the most vulnerable red cells, these cells actually increased remarkably after the patient increased the dose of pegcetacoplan. And this suggests to us that when we're using the C3 inhibitor, we are making the PNH cells to survive, and they become more vulnerable to the complement-mediated hemolysis. So the breakthrough hemolysis we are seeing in C3 inhibition is different to C5 inhibitor breakthrough hemolysis. The LDH is nearly 10 to 15 times upper limit normal. there is some higher disease discontinuation. But again, we need to remember these were high-risk patients on the Pegasus study. And the reason for that is that in the proximal complement inhibition, when you have got an incomplete inhibition, this process of C3b activating the C5 is an enzymatic cleavage, and C3b can activate multiple C5 molecules. As a result of that, you can have massive MAC storm, and that's why patients can get severe intravascular hemolysis. So you've got a large red cell PNH clone, you've got a short half-life of pegcetacoplan, and then there is an enzymatic cleavage in the proximal pathway, which gives an enormous amplification potential, which needs to be remembered when we are treating these patients in our practice.
Excuse me, 5 minutes, Doctor.
Okay. So in terms of what we can do, we can actually treat these patients with increasing doses, or we can give a C5 inhibitor. There are a number of other drugs which are coming along, oral tablets such as factor B and factor D inhibitors. There are mRNA techniques to reduce the production of C5 and C3, and there are MASP3 inhibitors as well. In terms of the oral inhibitors, factor D inhibitor danicopan was tried as an oral treatment, and they did improve the hemoglobin LDH. I think the drug needs to be given alongside eculizumab at this moment in time, as the single agent data suggests limited improvements, but this is a drug which is being developed at the moment. And the other one is the factor B inhibitor, which is an oral drug. And there are 2 cohorts in this study, and both of these 11 out of 12 patients became transfusion independent. This is again a proximal complement inhibitor. And the iptacopan is being used as in addition to eculizumab in one of the trials as well, and majority of the patients are benefiting from this drug. So I think in terms of the breakthrough hemolysis with proximal complement inhibitors, when we're using proximal complement inhibitors, we need to be remembering what's happening with these patients. The factor D concentration is 90 times lower than C3. So their breakthrough hemolysis is different to the C3 blockage. And there are strategies to counter that. We can adjust the dose of proximal inhibitors. A pegcetacoplan can be given every 3rd day, or we can give a proximal or a terminal inhibitor like eculizumab for a short period of time. These are the multiple trials which are looking at these questions. There are C5 inhibitors, subcutaneous drugs like crovalimab or pozelimab in combination with mRNA C5 inhibitor cemdisiran. And then we have got proximal inhibitors like pegcetacoplan, iptacopan, and danicopan being used in the trials. So I will conclude there that the treatment landscape of PNH is evolving. I think newer treatments are offering better outcomes and choice for PNH therapy. Revolutimab and pegcetacoplan are both approved, and selection of patients is important. Goal is to get perfect control with minimal side effects, but biosimilar and competition in the field is important. And I think cost of anti-complement therapy would be a significant issue for most healthcare systems. And I'll stop there.